now move on into the most fascinating address of the day by Dr. Sandeep Attawar. Dr. Sandeep Attawar is one of India's leading cardio-thoracic surgeons and a recognized expert in the field of heart and lung transplantation. Over 2 decades, he has conducted over 13,000 open and closed heart surgeries on adults, 3,500 procedures on children with congenital heart defects, and 400 on newborns, making him one of India's most experienced professionals by the age of 50. More recently, he has focused exclusively on rare and highly complex procedures like heart and lung transplantation. In the past 5 years, he has completed over 100 heart and 234 bilateral lung transplants, 44 combined heart and double lung transplants in adults. For context, in the 2 decades before Dr. Attawar's groundbreaking work, only 200 heart and 20 lung transplants have been conducted across India. He also has the highest 1-month survival and 1-year survival rates of any surgeon in the country who has performed more than 10% or lung transplants. During COVID, he completed over 31 double lung transplants, the highest single surgeon experience in the world. As of August 2022, Dr. Attawar is one of a small number of surgeons in the world authorized to perform LVAD, left ventricular assist device implantation. These cutting-edge devices are meant for patients with terminal and intractable heart failure. Dr. Attawar performed over 35 of these procedures, including the first pediatric LVAD outside of Europe, Japan, and North America. It is my great pleasure to invite Dr. Sandeep Attawar, who is all set to present on heart transplantation beyond the basics. Yeah. Can we have a big round of applause for Dr. Sandeep Attawar?
Good morning, ladies and gentlemen. I am extremely grateful for this opportunity. It's a great honor. I thank Dr. Brahma personally and Pharma leaders for giving me this chance to probably speak about something which might sound a little futuristic, but I'll try to make it simplified. It is a complex subject, I agree, but I think the presentation, which is 15 to 20 minutes, will take you through the basics of heart failure, what are the therapies for heart failure, what are the alternatives when we do not get a human heart for somebody suffering with end-stage heart failure, and latest medical advances as far as bioengineered hearts are concerned. Xeno Transplantation, you must have heard about a heart transplant being conducted by taking a pig heart and being used in a human after genetic modification. So I hope you find this exciting. I'll try to run you through some of it, keep it as basic as possible, so it's understandable to an audience that does not have much of a medical background as far as clinical medicine is concerned. If you can I just keep clicking the center one. Yeah. So it's unique. It's a unique organ. It's important to know that the heart beats 120,000 times a day, 42 million beats annually. It pumps 50 to 200 ml of blood every time it beats, and it pumps 3 billion times in an average human's lifespan. And it also distributes a network of roughly 100,000 miles of blood vessels. Every time it pumps 5 liters, it's an immensely adaptable pump, can increase its output up to 5 times. So from 5 liters it can pump nearly up to 15 to 18 liters every time, and it can change its speed. So it is the most versatile pump that was ever designed by evolution and nature. So you can understand what the consequence of a pump that fails can for a human being. These are the signs of heart failure. You have shortness of breath, you find it difficult to focus, you find early fatigue, you're confused because the circulation to the brain is reduced, you have a dry racking cough, you're not able to sleep flat, you have lowered ability to exercise, your diet goes down, your heart has palpitations, and you have swelling all over your body. This is the clinical course of heart failure. Now, I'll try to simplify it. If you look at the left upper side corner, you will notice that there is a emoji which signifies a reduction in heart function. So if the x-axis talks about heart function, which is detected with an echocardiogram, versus a plot of time, after the index event, let's say it was a heart attack, you would see that there are many compensatory mechanisms that come into play. With that, there is something we call a remodeling of the heart that happens with time. So as the heart increases in size because it is weak, there are certain secondary changes that set in and allows the heart to continue to compensate to a point where the heart starts failing and you clinically become significant, where you have end-stage heart failure. It is during this phase where you see a larger graph on the right-hand side where the x-axis shows the intensity of care and the quality of life. The quality of life keeps deteriorating as you get sicker, and your admissions to the hospital and the number of medications you take keeps increasing, and you reach this small ellipse here in the corner. This ellipse basically, the gray ellipse that you can see here, it largely tells you about a point where medicines have stopped working. And these are patients who are considered to have very advanced heart failure. Why is this important? Because if you look at this data from the US for the last 20 years, 2 decades, you can see that the average incidence of deaths from heart failure is roughly 300,000 annually. 300,000 people die every year because of advanced heart failure. And that trend has only incrementally increased in the last 4 years. There's a 24% rise in deaths from heart failure. When you look at this step ladder, at the bottom of the ladder, you will see patients who are diabetic, hypertensive, have hypercholesterolemia. They still do not have heart failure. But yes, because of hypertension, they do have certain changes in the shape of the heart and in the function of the heart. So you have medicines for this. Increasingly, as the heart starts getting damaged, you probably have to utilize therapies like angioplasty or stenting, coronary artery bypass. You might require valve replacements. Might require medications to not just control diabetes and hypertension, but you may also require pacemakers. Increasingly, as the hearts get sicker and weaker and patients are unable to tolerate any medicines anymore, we have to look at probably therapies that can look at either substituting the heart or changing it, or probably adding a device that could support the heart circulation by improving pumping. Now, this slide tells you about therapies on the top, which we already spoke about: bypass surgery, valve replacement, certain methods to resynchronize the heart, which is basically pacemaker therapy. There are some abandoned procedures in the right upper hand corner which we don't do anymore, but there are effective ways of supporting a weak heart, that is either by totally replacing it with a human organ or probably using a total artificial heart, completely made of physical matter, a mechanical heart. Or you can use assist devices which are individual pumps, small in size, which sit by the side of the heart and allow the heart to support and function. What is the challenge in India? Our problem is, like Dr. Brahma just mentioned a little while earlier, we have a lack of accurate estimates because we do not have surveillance. We also understand that as our population gets older, as the baby boomers get into their 60s, as we have epidemiological and health transitions, the population of heart failure in our country and the burden is increasing. We also know that compared to the rest of the world, where coronary artery disease, hypertension, obesity and diabetes are major contributors for heart disease, we know for sure in India we have a unique disease called rheumatic heart disease, where rheumatic heart disease can damage hearts significantly. This could lead to heart failure. So I presumably have a much larger number than this what you see on your screen in the left upper hand corner. 6.2 million adults in India suffer from advanced heart failure, end-stage heart failure. Of them, 600,000, 10% of them approximately, have very severe high-grade heart failure, where they are so sick that they probably are looking at the end of life within the next 24-48 months. And the median survival for patients who are in that window is only 2.5 years, in spite of the best medicines. What they need is, they need a human heart. We need to have over 350,000 hearts donated in this country every year to save these patients. Unfortunately, our donation numbers are dismal. How can you get a human heart? You can only get it when somebody passes away and post their death, their family decides to donate their organs. Our current donation rates are 1,000 per year. 1,000 organs are donated annually. We have serious problems with a legislative mechanism as far as the government making its best efforts to generally smoothen or streamline the process. We have challenges with us being a multi-faith, multi-racial society. We have many faiths, so we have many beliefs. There's also a problem of geography. A donor organ in Guwahati cannot be accessed by a recipient or a patient who requires the heart in Bombay because of logistics. So demand will always outstrip the need. This graph is just to show you a brief of what the status is worldwide. So in Spain, which has the highest donation rates in the world, they donate 40 donors per 1 million of population. In India, it is only 0.26 per million. That means when we need 500,000 life-saving organ donations annually, we have only 1,000 of them. It clearly tells us that hundreds and thousands of people every day in this country lose their lives because of the lack of a donor heart. So we have to look at something else. So when you look at out of the box, it's good to take some history lessons. Alternative to a human heart. This is a slide from the 1950s. The surgeon in the center is a physicist and an engineer. His name is Dr. John Gibbon. He invented the heart-lung machine in the 1950. The girl next to him, who now appears as his assistant, is the girl who had a hole in her heart. She was the first individual to undergo a heart operation, which allowed her to live long and live well. Dr. Gibbon used that implement on the left upper hand corner, which is called the earliest heart-lung machine, to cure her, and that probably design on the bottom is a cutaway or a CAD design of the pump head. This gentleman is Dr. Christian Barnard. Everyone would have heard his name. He did the world's first heart transplant in Grootskroon Hospital in South Africa. This was in December 1967. Unfortunately, the patient didn't survive long. But what he did was a miracle as far as medical science was concerned, because in those days, most patients never received hearts. They never knew that heart transplantation is an option. But once transplanted, there were many challenges related to infection and rejection of the new donor organ. Organs were always in short supply. So given all these challenges, while heart transplantation picked up, scientists and physicians and policymakers all over the world realized that you have to have a mechanical alternative or a substitute to a human heart. And unless both of these therapies emerged as complementary therapies, we would never have one of them overtake the other. So there came a need for us to have hearts that were mechanical by nature, which could support a failing circulation probably momentarily or for a longer duration. And there we come into two very remarkable feats. The man at the left upper hand side is Dr. DeBakey. Michael DeBakey was a US Army colonel. He is also the man who worked very closely with President Roosevelt and the National Institute of Heart and Lung Diseases and Blood in order to set up a foundation which worked towards the creation of the first artificial heart. This is a picture of a lady who underwent an aortic valve replacement and her heart did not recover after surgery. He used this small device to be able to support her failing heart for 10 days, following which the heart automatically recovered and she was able to go home. This picture in the center is a total artificial heart. It's called the Cooley-Leota heart. This was used by Professor Denton Cooley, who is one of the world's most remarkable cardiac surgeons whom everybody has heard about. He did this operation where he supported Mr. Haskell Karp on a total artificial heart for 3 days before he found a human heart which could then be transplanted to save this man's life. Unfortunately, because of multiple interventions, the patient did not survive the procedure, but these two procedures set the trend for future researchers to be able to figure a way on how we could have a total artificial or a partial assist device. So when human beings have challenges, they normally look at, we get into the field called biomimicry. We try to create implements which resemble human organs. So this early engineer who tried to fly using wings on his bicycle was probably an inspiration for people who started devising the first partial assist or the heart assist device, which we call the HeartMate XVE. This is a pulsatile pump. It would pump between 8 to 12 liters of blood every minute. It was partially used only to support the failing left ventricle. It had two tubes which would connect to the great hosepipe of the heart, which is called the aorta, and the blood inflow which came from the lung, which is pure blood, and it allowed the left ventricle to rest. The problem is it is a large device. It could only be used in large adults. It was implanted in the abdomen and the chest. Unfortunately, though it was made of pulsatile flexing membranes, it had reciprocating mechanisms, cams, gears and shafts, it would frequently break down. And it would unfortunately sometimes break down so catastrophically that patients would die. But in roughly 50% of patients, they survived more than 1 year, and 24% of patients survived more than 2 years on this device. This told us that we could actually find a solution for patients with end-stage heart failure when they did not get a heart on time and they were dying. This was a large, noisy implement. It was energy inefficient, and like I said, it was a very prohibitively risky operation to do once again. So these four groups of gentlemen, Dr. Michael DeBakey, whom I spoke about earlier, and the man in the picture is David Saucier. He is a NASA aeronautical scientist who underwent a heart transplant. He took it upon himself to devise a pump that could probably be used for failing human hearts. And he took his inspiration from the fuel injection pump that was used in the shuttle Saturn V, the Saturn V rocket. He used that device. It was used by Professor Richard Wampler, who was a cardiac surgeon, who devised the device, and implanted by Dr. Bud Frazier in 2003 December. This was the first device implanted in the world which used blood-soaked bearings. So the pump keeps rotating in a stream of blood and pushes it axially forward. One of the inspirations came from this village in Egypt, which used a pump which we call the Archimedes screw to pull water from a canal to a farm at a higher level. And you can see a cutaway of this design over here, and this is the animation of the pump. I wish I can run it for you. That is connected to the heart. It pulls blood through this pump in an axial fashion. As this impeller rotates, it is suspended in a magnetic field. As it rotates and pushes blood forward, it is propelled into the aorta, and that allows the heart to rest and makes this pump do all the work for this man with a failing heart. This is how it looks. 1/7 of the size of the initial pump, 1/4 of its weight, no valves, an axially flowing pump, better durability, noiseless, no breakdowns, more power efficient, and lasted much longer. There have been close to 24,000 of these implants worldwide. There are patients whom we have operated nearly 15 years ago who continue to do well on this pump. These are gentlemen between 60 to 70 years of age. So this was a second generation pump, remarkably effective. However, it still had some challenges, and as the human ingenuity progresses and as science progresses, we thought of new ways of developing a magnetically levitated pump. A pump that was suspended in a magnetic field which would propel blood by throwing it away rather than moving it axially. And that is why you can see that red stream in the cutaway down in the bottom, that is blood. There is a lot of space. The axis of rotation is perpendicular to the flow of blood. There is no noise. There is very low infection. This is a remarkably advanced pump. It is in use since 2014, and roughly 15,000 patients have had this pump. This is the latest design, and this is how it works. This is the cutaway of that pump, and as you see, it is completely suspended in a magnetic field with 12 magnets all around. Some of them permanent, and some of them which are actuated by an electrical current that runs through a drive line. It is a noiseless pump. It does not create any blood damage. It does not stop on its own. It has an effective pumping feature of between 8 to 12 liters of blood at times, and it is very safe to all the blood that circulates it, 5 to 7 liters per minute. This is a figure that tells you of all the patients in the United States who require a heart transplant or an assist device, which number is around 600,000, only 4 to 5,000 implants get done. In spite of a country which is so advanced, has limitless potential to make these machines, has no resource or insurance dearth as far as funding these patients. In India, we can do better. We can probably look at figuring out how we can develop a device like this in our own laboratories, and we can use it in the therapy and treatment of many of our patients. All the others are going to be futuristic. I'll take 5 minutes to run through it without taking too much of your time. This is a device we call the Transmedics. It is an organ care device. It is used to expand the donor pool. So there are some patients whose hearts have stopped circulating and the families are willing to donate. If we have 30 to 60 minutes, we could open the chest of that donor in the theater, pick up the heart, put it on this machine and revive it. We can circulate blood and nutrients through this heart. It will start pumping again on this machine. We will use methods to identify and augment cardiac function. We have the capability to do an angiogram on this heart. We can do an ultrasound. We can measure the blood lactate in the venous return and figure out how to improve the quality of this organ. When demonstrated to be good for use, we could explant it and use it to save a human life. That was one. And we can now have therapies which call biological substitutes. So there are many donor hearts that may not be utilized. They could be picked up, taken to a bioengineering facility, and they could be suspended in a solution of detergent. Detergent is the working definition, but these are medical detergents. When pumped through the aorta, they would decellularize the heart. They would strip off all the muscle. They would strip off every single cell in the heart except a fibrous skeleton. That skeleton could then be populated once again with cells we call progenitor cells, which are from the patient's own body. You take a tissue of skin, you identify those cells, multiply them, and take them back to a stage we call pluripotentiality. That is like a stem cell being taken from an embryo. So you reverse engineer your own cells and put them into this scaffold, the vascular cells where they go, the muscles where they go, and you can bioengineer a human heart in 3 to 6 months. So, for example, I am suffering from heart failure. I could use this platform if I have a lot of money, and I could actually bioengineer a heart for myself. We could be used to transplant me 6 months down the line, and I will not need any medicines to prevent a rejection, because that is my own cell. It is my own heart. So this is possible, and it is being done right now. It's a proof of concept in the laboratory. But the important part is we have to use that heart and put it in a bioreactor, which will train the heart to pump in a systematic fashion, and for it to be able to do that work. We also have technologies which allow us to do 3D bioprinting of the same skeleton, but unfortunately right now we can do small and complex structures, we can't do large structures. Big organs are potentially possible but still not completely feasible. In the laboratory we have created cardiac conduction cells. We have created strips of heart muscle that beat on their own when electrically stimulated. But there are some challenges, like I said. We need billions of dollars. We need a lot of trained staff. We need 365-day efficiencies. We need liters and liters of bioreactor fluid, and we need tools and assays that we still have to build. So lastly, 3 slides, Xeno Transplantation. So Churchill once said, I'm fond of pigs, dogs look up at us, cats look down on us, pigs treat us as equals. So the best alternative for us right now, and the easiest fruit, low-hanging fruit, seems to be organs coming from pigs. These pigs are not the pigs that you see on the street. They are cultivated and they are nurtured in germ-free laboratories. They can be the closest match for humans, simply because of our genetic match is nearly 97% of our DNA matches with the pig DNA, unfortunately. That's why some of us behave like them. We can sometimes breed them in controlled circumstances. There are physiological similarities. We can genetically modify many of these pigs to make them reservoirs for donor organs for humans. We can treat them with antibiotics. We can vaccinate them, and a million other things. But there are a few challenges, and the most important being the transmission of a virus we call the cytomegalovirus from a pig to a human. That has been taken care of. We have mechanisms to eliminate the cytomegalovirus, and what is most important is this DNA clipping tool. We call it CRISPR-Cas9. That is an enzyme that allows us to remove the pig's DNA, which have an endogenous map for a retrovirus. A retrovirus is a lethal virus which comes into the human population, can create the same havoc that COVID caused in human beings a few years ago after vertical transmission. So our technology allows us to remove these genes. We now have pigs that have saved the life of this gentleman. This operation was done 6 months ago. Unfortunately, the patient did not survive more than 2 years, but the proof of concept was proven by Dr. Bartley Griffith and his team at the University of Maryland in Baltimore, where they did this first successful pig heart transplant. This gentleman is doing well after the operation. So in conclusion, while we have significantly low donation rates in our country, a lot can be done. We know that for a human being suffering from end-stage heart failure, the only option is probably a donor organ, which is a limited resource right now. It's time that we, as a country that is so developed, we have put machines on Mars. We have our own naval battleship, probably one of the few countries to have our own advanced military platform, naval platform, that is the aircraft carrier. We have an ability and a capability to devise all of these and produce them in mass numbers at a much, much reduced cost. So I think that's a focus that our medical device industry must look at. There are many other alternatives, as I spoke to you about, but they are still evolving and they're utopian in their concept. An indigenous LVAD is the low-hanging fruit. I dedicate my talk to Professor Michael DeBakey, who has been an inspiration to many of my colleagues and me personally, for everything that he's done for the field of artificial circulation and mechanical circulatory support. I thank you for your time and your patience.
Thank you, Dr. Sandeep Attawar, for your insightful talk. Now I request Dr. Satya Brahma to be on stage to present a memento as a mark of respect to him.
So actually, Dr. Sandeep had given me a time for the entire day. Then he had to transplant someone, heart transplant someone. So he's going to Kokilabai, Dhirubhai, HN Reliance is going it. So his wife will pick up the award later on. But what a fantastic personality. 13,000 open heart surgeries and so much of he's doing it actually. So I think next 4 to 5 years line, he is going to be the most admired cardiologist of India actually. After Dr. Ramakant Pandey, then Dr. Naresh Trehan and Dr. Bhattacharya, then all other person, he is going to be the next thing actually. So that's what I like you most about it. You're very innovative. Thank you for coming on the show and it's my real pleasure actually. Please come. Yeah. A small moment is good because you can keep it. Yeah, thank you. Thank you. Thank you so much. Tell your wife to come and